Hello, my name is Alex Weeman, and I'm a third-year occupational therapy capstone student. Today, I will be presenting on models of care for survivors of stroke. In particular, I will be focusing on our current model of care and the transition back to home and to the community, and I will explore alternative models or potentially beneficial changes to the current model. Stroke recovery typically begins with an acute hospital stay, where the healthcare team develops strategies to prevent recurrence of stroke, facilitate management of new needs, reduce incidence of further complications, improve quality of life, and increase access to specialists when they are needed. This is also when the rehabilitation team begins working with survivors. Survivors are often discharged early from acute care to receive rehabilitation services while living in the home environment, and if survivors are not functionally ready to return home yet, their stay in acute care remains brief as they are then transitioned to other inpatient rehabilitation settings. One of the central purposes of rehabilitation services in the transition back to the home environment is to facilitate community reintegration, which following a stroke is the re-engagement in previous life roles in meaningful occupations, especially within the community setting. After returning home, care transitions to the community setting where the goal is to continue the recovery process, maintain health, and pursue reintegration. Much of this education that the therapy team provides to ease this transition is directed towards the care partners of the survivors, as the new impairments and deficits experienced from the stroke lead survivors to turn to their families and loved ones to support their needs. As a result, care partners become essential in facilitating rehabilitation within the home environment after discharge from the hospital and from other therapy services. Several challenges manifest during the transition back home and back to the community. While survivors who have returned home often undergo rehabilitation therapy in their homes and in outpatient clinics, goals are sometimes not achieved, and community reintegration can remain a challenge for survivors long after outpatient therapy ends. Many survivors continue to experience impairments in a variety of areas that impede their reintegration into the community, including social functioning, home duties, and community mobility as a few examples. Without the same level of engagement in previous life roles and activities, many survivors experience psychological consequences such as depression, anxiety, and feelings of isolation. Furthermore, the loss of autonomy and self-esteem affect many survivors after returning home, and decreases in these areas are directly tied to a decline in physical, psychological, and spiritual well-being. Additionally, caregivers are often heavily affected by their new roles following their survivors' transition to home, leading to increased burden and sometimes social isolation, depression, and declined physical health. In turn, when the care partner is experiencing these negative consequences of increased burden, the survivor can experience a decline in health as well, and the recovery process can sometimes reverse and lead towards rapid admission to institutional care. Much of the challenge of taking on the role of a care partner stems from the education received prior to discharge and the support given throughout the transition to home. Care partners are often not provided with adequate training or education to perform their new roles to the fullest upon returning home, and this negatively affects the quality of care that the survivors receive as a result. However, even when care partners receive ample education prior to their survivor's discharge, they often do not feel confident or prepared for their new responsibilities when returning home. These experiences that survivors and their care partners undergo suggests that the current model of care has notable shortcomings. While the current model of care has its benefits, it has areas of weakness that leave many survivors underserved. For instance, lengths of stay allowed for inpatient stroke rehabilitation have decreased significantly, forcing survivors to return home prematurely. This presents additional stress for care partners who are underprepared for the return home, and it puts pressure on the therapy team to educate care partners thoroughly despite time constraints. When care partners' education does occur, health professions deliver a vast amount of information in a short time, and the care partners leave feeling overwhelmed and uncertain. Furthermore, in the acute setting, many care partners are still at a phase of shock and emotional turmoil following their loved ones having a stroke, and most care partners are not prepared for education while they are still processing their emotions. Survivors also experience a lack of education needed for transitioning back to the home and to the community, and they feel that their information needs have not been met by the healthcare team and the hospital. Survivors frequently report feeling that they are not adequately informed or incorporated into the decision-making process when preparing for discharge, and this negatively affects their mental health and motivation. With the limitations in education, issues arise after survivors leave the hospital, including a lack of support upon returning home that leads to difficulty coping with the life changes and neglected care needs. Additionally, few supports and services are typically available within the community setting, which further limits the ability for survivors and care partners to reintegrate smoothly. Even with home health and outpatient therapy services available, other services that might be essential for community reintegration are often not readily apparent, and the limited time allowed for those final therapy services can be limiting for the long-term success of many survivors. Strategies to overcome the challenges of the current model of care tended to fall into 4 categories: timing of education, community services, leisure engagement, and community-based programs. When looking at timing of education, one of the recommendations that has been suggested is to focus on increasing communication between health professionals and care partners, as well as to provide multiple forms of information, such as in verbal and written forms. However, this recommendation does not acknowledge the remaining time limitations in the hospital and the gaps in knowledge that can still occur during the transition home. Another way that clinical researchers have recommended to overcome the time constraints is to begin care partner education at the beginning of care. Unfortunately, this still neglects the limitations of care partners' schedules, as well as the fact that care partners will have greater grief, emotional turmoil, and feelings of being overwhelmed if the education process simply started earlier within the already constrained time at the hospital. Another proposed solution, called the Timing It Right model, focuses on timing different parts of education to make it more effective following a stroke. The key principle of this model is that care partners require different education and support at different periods in the rehabilitation process, and healthcare providers should consider what information and what approach to education is most appropriate at each specific stage a care partner is at, such as the acute phase versus returning to home. Encouraging a focus on meeting education needs based on the recovery context is an effective method that could facilitate the transition of care. While this approach should be implemented in all health systems, timing it right would center on the training and skills of healthcare professionals rather than a modification to the basic infrastructure of the model of care, and time constraints would remain as systemic barriers. Therefore, additional changes to the model should be explored to best serve survivors. Another strategy to overcome the challenges of the current model of care is to focus on social and community support, which are factors that have been associated with decreased hospital readmission. One recommendation is to respond to the decreased time allowed for hospital stays by connecting stroke systems of care to services beyond outpatient and home health services. Some of these services include community exercise programs, fall prevention programs, support groups, and several others. This will provide further support to survivors and care partners to continue their journey of improvement alongside the rehabilitation services that may still be available to them. Implementing a variety of services throughout each community should be a priority, especially for survivors to continue pursuing their goals independently of formal rehabilitation services for an unrestricted length of time. To facilitate the pursuit of community services and resources during survivors' transition home, the healthcare system in the community should educate survivors as well as develop resources that are culturally inclusive to be as accessible as possible and to have the most impact on community reintegration. As such, resources should be developed to overcome language barriers, differences in values, and diverse interests alongside being accessible for survivors with a variety of post-stroke deficits. Another strategy is the navigation approach. This approach comprises of the coordinated involvement of survivors alongside multiple community groups, health-oriented organizations, and social supports who can best inform survivors of the opportunities available to them. To assist in this process, a member of the care team would guide each survivor through timely and appropriate access to these resources in a process called navigation, which ultimately would continue until survivors have experienced successful community reintegration. This would result in improved social health and reduced caregiver burden. Although this approach could be challenging to implement within healthcare systems, it provides an initial framework for improving the reintegration process. Another strategy is to increase engagement in leisure and recreation activities, which are powerful coping mechanisms during challenging times. Unfortunately, following a stroke, involvement in chosen leisure activities decreases due to new deficits and other barriers that inhibit participation, resulting in a decline in life satisfaction. Efforts to improve access to leisure activities are therefore vital, especially with the variety of benefits that are associated with leisure in a community setting, including redevelopment of social roles and enhanced autonomy for survivors. Furthermore, social recreation and leisure positively impact survivors' community engagement and social support during their recovery. As a result, survivors develop increased hope and better community reintegration outcomes. One final strategy to discuss is the implementation of community-based programs. Community-based programs allow for a flexible yet permanent option for community reintegration strategies that continue addressing or maintaining survivors' goals where other rehabilitation services may have ended short of. These programs also reduce caregiver burden significantly by allowing care partners time to themselves during the day without having to be in direct care of their loved ones. Programs can incorporate a variety of resources into one space to ease the transition back to the community so survivors and care partners do not need as much extensive education to determine their needs, and less effort would be required to locate these resources when they're all combined. Activities that may be included in a typical community-based day program could include educational sessions, physical exercises modified for survivors' deficits, craft activities to address fine motor skills, games to address cognitive skills, and group discussions to facilitate psychosocial well-being. While community-based programs are rare nationally, a few have been established despite existing outside the traditional model of care. Existing community programs for survivors of stroke have managed to help to resolve or positively impact survivors' social, physical, emotional, and cognitive challenges that they have faced, and addressing these issues has ultimately led to improved community reintegration. Furthermore, involvement in a community-based program allows survivors to build relationships and a community identity away from other settings where stigma related to disabilities can sometimes inhibit social reintegration. These programs are opportunities for survivors to regain their autonomy within a group of people with shared goals and interests, and this would be a significant step forward in their collective journey towards recovery. After reviewing the various solutions to improve care and reintegration of survivors of stroke, each potential modification comes with distinct strengths and weaknesses. All modifications could be beneficial in certain contexts or when implemented together. However, community-based programs could make the largest positive impact on survivors while also having minimal downside beyond the initial investment necessary for implementation. The availability of programs for survivors would allow them to have long-term support for their goals and general health, and programs would provide a community setting to build a new social support system within. Care partners would also have additional time to themselves while survivors have more autonomy and independence in the activities they engage in at the program. Furthermore, if a navigation approach for resource identification is in place prior to discharge, the process would be simplified due to a variety of community resources being centralized and accessible through one organization that would also be available to facilitate the transition to home. Community-based programs could also ease the pressure placed on healthcare educators, as professionals in community programs could take over education duties following the return to home. Of course, this solution may not be a one-size-fits-all. Certain individuals may not be able to attend programs for a variety of reasons. Programs may not be feasibly implemented in smaller population areas and rural communities as well. However, in communities where the implementation of community-based programs is feasible, many survivors of stroke and their loved ones could see overwhelming benefits as they have the supports that they need. To transition our current model of care to include community-based programs, advocacy would be essential for bringing attention to its potential. Sharing information of existing programs on social media or contacting programs to learn more about their needs are just a couple of forms of advocacy that could be pursued. For people who hope to implement a community-based program, initially focusing on larger population areas that are underserved is a strategic way to ensure greater opportunities for survivor participation, as well as to ensure a sufficient availability of resources that could be consolidated. Additionally, involving a variety of professions within the program would help to develop a holistic perspective when creating activities, locating resources, and determining priorities for the program. Finally, staying involved with survivors of stroke and their families could help to identify needs in those who could use the program in the future, and those same individuals could potentially be recruited as initial participants. Thank you for joining me in this presentation. Here are my references. Here are additional references. And here are the final references.